and welcome to Let's Talk Dementia. I'm Sarah McCormack, the National Lead for Healthy Ireland in the HSE. And today we have a very large audience. We have over 1,700 registered for this session. And I'm not surprised at that, because when we actually look and see that there are over 64,000 people living in Ireland with dementia. And anyone can get dementia, and even dementia at the young age of 30, 40 and 50 years of age. So today we are here talking about dementia because we want to increase the knowledge and awareness of all the population on dementia. We want to share with you the information on the services that are available in the health service. And we also want to bring to your knowledge the wonderful role that the community can play in building a supportive and a collective community to support people with dementia. Now, getting a dementia diagnosis is challenging. Just think about it. If any of us were told you have dementia. But what's really important is that there's great hope even with getting that difficult diagnosis of dementia. And you will hear today from our speakers that we can live and live well with dementia. And really important in helping people to live well with dementia is about building the community and the supports, and we all can play that role in doing so. So today, as we go through, you can help us on the social media, so you can go out there and you can use #Let'sTalkDementia. And also, we have the opportunity for you to put your questions in. And today we are using Mentimeter. So for Mentimeter, you can use your phone, and you will actually see, coming up on the screen there now, is the QR code. So you can just scan the QR code, and then you will be straight into Mentimeter, and you will be able to put your question in there. And we really want to hear your questions, because that is what we are here today, is to share the information and to answer any questions and thoughts that you have. So I'm delighted that we have a great panel of people who have developed a great expertise in this area. And the first person I want to introduce you to is to Dr. Seán O'Dowd. So, Seán, you can join me here, Dr. Seán O'Dowd. And Seán is a consultant neurologist with a special interest in cognitive disorders and dementia. And Seán has been our clinical lead here with the National Dementia Services since October 2022. So Seán, over to you to start sharing our information today on Let's Talk Dementia.
Thanks very much, Sarah. My name is Seán O'Dowd. I'm a consultant neurologist at Tallaght University Hospital, and I'm the clinical lead at the HSE's National Dementia Services. And I'm just going to provide a kind of a broad overview to the topic of dementia. After this talk, I hope that the audience might have a better understanding of what is dementia and what does the term mild cognitive impairment mean, because sometimes there can be confusion about the overlap between those two terms. What are the different types of dementia? What are the signs and symptoms of dementia? And maybe an understanding of what some of the risk factors for dementia are. Excuse me. I'd like to outline what the 2023 model of care for dementia sets out for the diagnosis and care of those affected by dementia, and what we can do in our communities to support those living with dementia. So what is dementia? So dementia is a broad term, or we sometimes use the phrase an umbrella term, to describe a progressive decline in a person's cognitive or thinking abilities, which impacts on their ability to function day to day independently. And while the classical cognitive domain or area of cognition that's affected is memory, it can also affect other aspects of our cognition, such as, for example, our language skills, our ability to plan and multitask and make decisions and judgments, visio-perceptual abilities, or behavioural or social skills. And dementia is not a single disorder. There are numerous causes, but the vast majority of those causes are what we call neurodegenerative diseases, which are caused because of certain proteins in our nerve cells which begin to behave abnormally and clump together and cause those nerve cells in the brain to stop working as they would normally. So there are a lot of misconceptions about what dementia is and is not, and they traverse both the public sector and the healthcare sector. Dementia is not just aging, and it's not a part of normal aging. And it's not a single disease or diagnosis. It's a term which describes a non-specific syndrome. And as I've said, there are many potential causes. The same as cancer, there are lots of different types of cancer. And if you met somebody who said they had a diagnosis of cancer, particularly in a healthcare setting, you'd probably want to know what type they have. And the same is true for dementia, because there are many different types. Nobody is immune to the possibility of developing dementia, and it traverses all walks of life, from politics through sporting, through ordinary everyday members of the public. So what's mild cognitive impairment, or sometimes referred to in the abbreviation MCI? So MCI is a syndrome describing difficulty or a change or a drop-off in your cognitive skills in one domain of thinking, be that, say, memory, for example, but which has not led to impairment in everyday functioning. So in many respects, it's a prodrome, or the forerunner of dementia. Now, it's not always irreversible, and not everybody with mild cognitive impairment will progress to develop functional loss or dementia. But everybody who has dementia at some stage would have gone through a phase of prodromal symptoms or mild cognitive impairment. And as we speak about the importance of early diagnosis, it's really important that we recognise people who are developing mild cognitive impairment. So as Sarah said, there are over 64,000 people living with a diagnosis of dementia in Ireland at present, and because ageing is one of the greatest risk factors for dementia, and as our population ages, that number is going to increase very significantly over the next 20 years, with a projection that we'll have over 150,000 people in Ireland with a diagnosis of dementia by 2045. So clearly this has a huge impact, both very obviously at a personal level and on families, but also on our healthcare system and society as a whole. At any one time, 1 in 4 people in a hospital bed have a diagnosis of dementia. 3 out of 4 of those in residential care have a diagnosis of dementia. And in our day-to-day personal lives, 1 in every 2 of us will care for or support somebody in our inner circle with dementia. So it's clear that we need to improve diagnosis, care and support for those who are affected, and find ways to prevent it. So what are the types of dementia? So the most common and probably best recognised type of dementia is Alzheimer's disease. And that's responsible for probably about 2/3 of cases. The next most common type of dementia is Lewy body disease, which is probably not as well recognised or felt to be rare, but in fact it's responsible for about 1 in 10 cases of people who have dementia. That's followed by vascular dementia. There's an important point here that vascular risk factors very often contribute to our risk of dementia and can complicate or accelerate the course of dementias like Alzheimer's disease. And sometimes you'll hear the term mixed dementia used to recognise that vascular contribution to the person's difficulties. But a pure vascular dementia as the only cause is responsible perhaps for about 5 to 10% of cases. There's a condition called frontotemporal dementia, which is responsible for probably somewhere between 2 to 5% of cases. However, this disproportionately affects younger people under the age of 65. And then there are a plethora of other rarer causes, each with their own unique signature of difficulties, such as, for example, the dementia associated with some of the atypical Parkinsonian disorders like PSP or corticobasal disorders, or Huntington's disease, or dementias associated with alcohol, such as Korsakov's dementia, and many more. So the phrase subtyping is sometimes used to describe the clinical efforts to identify the cause of somebody's dementia and the underlying disease. And no more than in most healthcare systems, we're not very good at this and need to get better. And we know from the Irish National Audit of Dementia Care from 2019 that only about half of people who have a known diagnosis of dementia had their subtype documented or known to the healthcare staff. So a few words about the different types of dementia, how they present, and what type of symptoms and difficulties people might have. So the most common is Alzheimer's disease. This is caused by 2 proteins in our brain which begin to clump together, called amyloid and tau. And most commonly, this presents with difficulties that we call amnestic in nature, so problems with rapid forgetting or episodic memory impairment. And invariably, the person will have some mild cognitive impairment or amnestic MCI, mild difficulty with memory that will progress to become more impactful in terms of day-to-day function and indeed to involve other domains of cognition. So episodic memory impairment refers to that difficulty where somebody has with recall of lived experiences, passages of time, meetings, family occasions, holidays, something that really they were very much present for and engaged with, but then rapidly forget. And that's sometimes an important distinction from that very brief, immediate memory, attention span difficulty that we can all have where we've misplaced our keys. So this is a really striking difficulty with recall of events that have happened. There are non-memory type presentations of Alzheimer's disease as well, and sometimes these are not recognised or take longer to be diagnosed. And people with these types of Alzheimer's disease variants have a longer journey, sometimes characterised by a lot of frustration, to be diagnosed. These types of presentations are more common in younger people under 65. So there's a language-led variant called logopenic aphasia, characterised by difficulty with word finding. There's a visual variant termed posterior cortical atrophy, and there's a behavioural variant or difficulty with judgment and planning that can be manifestations of early features of Alzheimer's disease. And then there's another type, more rarely, where movement can be affected as well as thinking, which is called corticobasal syndrome. The second most common cause is Lewy body dementia. This is due to a different type of protein, a protein called alpha-synuclein, clumping together and aggregating in our nerve cells into things that are called Lewy bodies, seen under the microscope. And this presents typically with problems with planning and judgment and multitasking and sustaining attention and sometimes visuoperceptual problems rather than day-to-day forgetfulness. So a non-amnestic type of presentation. And characteristically, people affected by this type of dementia will have some other features, such as sometimes very striking fluctuations or big changes in their ability and their clarity of thought from hour to hour or day to day. And 3/4 of people with this condition will experience visual hallucinations, often not frightening or distressing, but sometimes can be. Similarly, about 3/4 of people will have Parkinsonism, so difficulty with their speed of movement. And there's a very characteristic sleep disorder that can be a forerunner of this disease for many years, characterised by people thrashing about and moving and enacting their dreams. And Lewy body dementia, we'll all have seen it if we work in healthcare, particularly in the acute sector, because it presents very classically as a delirium, or can present. These patients are very prone to delirium. And that's something that can, of course, lead to its own very marked difficulties. Frontotemporal dementia, as I said, is overrepresented somewhat. It's relatively rare, but it's overrepresented in those who present with cognitive difficulties under the age of 65. Again, there are different proteins involved in this. It can either be tau protein or another protein called TDP43. And there are a few different types of frontotemporal dementia. 2 of them affect our language skills. Probably the most striking and disabling one is termed behavioural variant frontotemporal dementia, which has a very significant impact on the person's social and interpersonal skills. And there can be an overlap in a certain percentage of cases between frontotemporal dementia and motor neuron disease. So I've spoken a lot about the cognitive symptoms and presenting cognitive difficulties of dementia, but perhaps an even bigger difficulty as dementia advances can be the non-cognitive symptoms. And these can be characterised in broad terms as affective symptoms, psychotic symptoms, or some other behavioural symptoms. So affective symptoms include things like anxiety, depression, apathy. Psychotic symptoms include symptoms such as delusions or hallucinations. And then behavioural symptoms such as agitation, pacing, or repetitive perseverative behaviours or disinhibition tend to be something that can often cause a lot of consternation in the healthcare system and sometimes lead to prescribing of medications as sedative effects, although the evidence base for the value of those medications is really questionable or absent. And the overuse of those medications in our healthcare system has been recognised, as it has in others. And a national clinical guideline has been published in order to try to address this. This is National Clinical Guideline number 21, which focuses on appropriate prescribing of psychotropic medications for non-cognitive symptoms of dementia. Often people will ask, what are the risk factors for dementia? And very often people in the clinic, if they're attending with a loved one who's been affected, will ask about their risk. So there are certain things that we cannot modify, like our age or our gender, but we do know that there are 14 potentially modifiable risk factors for dementia. These have been catalogued by the Lancet Commission, and they're responsible for potentially up to 45% of dementia cases. And many of these are lifestyle related and relate to how we live our lives during our working years with discretionary behaviours such as the amount of exercise we take, our diet, our weight, alcohol, smoking, amongst others. And undoubtedly, prevention is better than cure. So in any healthcare setting where we identify any of these risk factors in somebody that we're seeing for any reason, it's really important that we try to address the role and the benefit for trying to minimise those risks. So from the context of the health service, we know that less than 40% of cases in Ireland of dementia are diagnosed. We know from data like that given by INAD that even fewer have a type of dementia assigned. And this leads to missed opportunities for appropriate symptomatic treatments and cognitive therapies, so pharmacological and non-pharmacological supports. It can lead to inappropriate prescribing of medication. And importantly, it often means that there are opportunities lost for advanced care planning, where the person can be at the centre of that, and opportunities to provide support to families and education. And ultimately, the lack of early diagnosis and information for people with these conditions in their families can often lend itself to inappropriate hospital admissions and premature transfer to long-term care. And we know that the cost of that at a personal level, but also to the health service, is very, very significant. And we know that in the acute sector, that people with dementia who are admitted to hospital often unnecessarily have much worse outcomes. So the model of care, which was published in May of 2023, is designed to address some of the system's shortcomings about enhancing earlier recognition and intervention for those living with dementia, and provides an integrated framework to bring together a wide range of services into a coherent pathway for people living with dementia. It sets out a range of ambitious but appropriate targets and practice recommendations to advance how well we assess and diagnose people with pre-dementia states and dementia itself, and the treatment, care and support for those affected. The services are configured over 3 tiers, with level 1 referring to assessment in primary care by general practitioners or those working in the enhanced community care programmes. Level 2 refers to the memory assessment and support services, which generally have a focus on typical memory difficulties, amnestic presentations in older people. And Level 3 refer to a smaller number of regional specialist memory clinics, which cater for more complex, younger or atypical forms of dementia. And there's one national intellectual disability memory service in Tallaght, which looks after those who have memory difficulties and new cognitive problems arising in the context of prior intellectual disability, particularly Down syndrome, given the very high risk that people with Down syndrome have genetically to develop Alzheimer's disease. So in our community, I think it's important that we go home from work and that we understand that 2/3 of those in Ireland who have a diagnosis of dementia live amongst us in the community, not in a residential care facility or anywhere else. And the Dementia Understand Together campaign is an advocacy initiative which is supported by a number of bodies like the HSE, the Alzheimer's Society and others. And it's really designed to support those living with dementia to live well in our communities with this diagnosis. And some of the key messages from those affected by dementia and those who support them include asking us to see the person and not the dementia, asking us to talk more about dementia. And I think that's really important because we need to destigmatise dementia so that people are less concerned and less worried about coming forward for assessment so they can get the support they need in a timely fashion. And we really try to emphasise the importance of staying in touch with those who are affected and supporting them and keeping up their hobbies, their interests, and asking how you can help. And from a healthcare and indeed a community perspective, it's really important that we give a little bit of thought to whether where we work or where we play is somewhere that is safe and easy and accessible to use by those who might be affected by dementia. So some take-home messages. Dementia has many faces. It is not a single diagnosis, and there are many different diseases and different expressions of how somebody can be affected. Early diagnosis, we know from the evidence, does improve quality of life. As Sarah said, it's not an easy diagnosis to get, and it can be a very difficult thing for people to accept, but we know that early diagnosis does ultimately lead to better outcomes in terms of quality of life for those who are affected. It also facilitates autonomy and provides for that important contribution that the person themselves makes to decision making about their care and their future. So if you meet somebody in day-to-day work who you think might have signs or symptoms of an undiagnosed dementia or mild cognitive impairment, support them to seek a diagnosis and an assessment. And remember that most people who have dementia in Ireland are living in our communities, so be dementia aware both inside and outside of the workplace. So I'm just going to pass over to a short video clip now, which has been provided by Marguerite Keating. Marguerite is the Vice Chair of the Irish Dementia Working Group and a member of the Understand Together Working Group. Marguerite's living with a diagnosis of young onset Alzheimer's disease, and she's a passionate advocate for people who have been affected by dementia. Thank you.
Dementia was a bad word in this country for a long time. Having a memory problem or a cognition problem is a lot easier to roll off your tongue than saying you have dementia. My diagnosis was when I was 55. They were saying to me at work that, I wasn't myself, and they asked me to go to see somebody. They told me that I had early onset Alzheimer's, and I found that very, very frightening. When it's personal, it's kind of, it's confronting. I felt to me like almost like a prison sentence. If you're labelled with something, it sort of chips at you, it takes something away from you. And we kind of need to fight and say, well, it's okay. I'm very passionate about having memory cafes here in Ireland and locally and all around, because there are a lot of people not ready for daycare centres. So I find that the memory cafe get people out, they get them engaged. It's very fun, it's very informal. The cafes mean that people with dementia can feel safe. They told me I'd have around 7 years, and I'm gone into my 6th year now. I don't feel like I'm anywhere near putting me riding boots up yet. I have this thing, about being remembered. It's not really important to me. What's important to me is that I fight for the Marguerites coming behind me.
Thank you very much, and I want to say thanks to Marguerite for making that video and sharing her own life experiences with us. And as she said, she wants to fight for the Marguerites coming behind us. So as you can see, I'm joined here by a number of people. And as I referred to earlier, these are people who have a great expertise in the whole area of dementia. You now know Dr. Seán O'Dowd very well from the presentation, and Seán, I will be coming back to you. And sitting here beside Seán is Matthew Gibb, and Matthew is the Director of Dementia Services Information and Development Centre. And then next to Matthew, we have Majella O'Donnell, and Majella currently works as the Clinical Nurse Specialist Dementia in the Memory Assessment and Support Team in Sligo. And beside Majella, we have Ken Greaney. Now, Ken is the outsider to the HSE here today. And Ken, I thank you particularly in coming with us, because Ken is coming and sharing with his experience, because Ken has over 15 years experience of supporting his dad, who is living with Lewy body dementia. So we look forward to hearing your story here today. And of course, Ken, you have been a real great advocate in this whole area of Lewy body dementia. You are a co-founder of the Lewy Body Ireland. So lots to hear from you, Ken. And then we have Emma O'Brien at the very end here, and Em is a senior occupational therapist in the Memory Technology Resource Rooms in South Tipperary. So, as I promised you, we have great expertise, so we want to get into the discussion and we want to get talking about dementia. But before that, I want to remind you, because we have over 1,700 of you here registered for this session today, is that we want to hear your questions. So don't forget, you have got Mentimeter there, and you will actually have the QR code. You can scan the QR code on your phone, and you can actually enter your questions in there, and we will be taking those questions as we go along from it. So, Seán, you made a wonderful presentation there to us, and real things that actually drew out in that presentation. A lot of information, and the great thing is this is recorded, so we will have that information to come back to. And I think some things you said there, see the person, not the dementia, right, in relation to it and about living with it. But you talked a lot there about dementia as the umbrella term for a range of diseases that damage the nerve cells in the brain. Why is it so important for us to understand the different types of dementia better and some of the signs and symptoms that are actually associated with them?
So thanks, Sarah. I think it's important for lots of reasons. I think it's important for today, for the people who are affected by dementia today, but it's also important for tomorrow, by the people who will be affected in years to come, that we get a little bit better at understanding the underlying causes of dementia and identifying those so that we can make timely interventions that are targeted towards the type of dementia that somebody has. So I suppose in the current context, it's important the treatments that we have from a pharmacological and a non-pharmacological perspective are symptomatic. They help with symptoms. They don't slow down or change the course of the disease, but they can certainly impact in a meaningful way on quality of life. But depending on the type of dementia, the cause of dementia, some treatments work, others don't, others could potentially be harmful in certain settings. So that's why, it's really important that we do our utmost to try to clarify the cause, the type, the subtype of dementia that somebody has who we're dealing with in a healthcare scenario at present. And in terms of the future, I think it's important that we have a better understanding. Dementia has sort of lagged behind, perhaps, some of the other areas that have developed more rapidly in healthcare in recent decades, like cancer, for example, or cardiovascular health. And we're getting there slowly but surely. But part of that journey is recognising that dementia is not just one diagnosis. There are lots of underlying potential causes, and trying to tease out as early as we can, both for the individual, their family, but also for the generation to come, as to what the cause is and how it could best be treated is really important.
And Seán, in your presentation there this morning, you mentioned about looking at the changes, in our own or our loved ones' memory and the behaviour that goes with that. If we notice that around us, for ourselves, or for those around us, what would be your advice to us?
So I think the first thing I would say is don't be afraid to ask the question about whether your cognition, your memory should be looked at. Because there often is a hesitance or a reticence or a sort of a stigma about admitting to concerns about memory, but this is common. We know that in our communities, lots of people are living with these difficulties, so there's lots of good support out there if somebody has a clarified diagnosis of dementia. So in terms of a route for assessment, the first port of call is the tried and trusted route through the family GP, who are, very skilled in teasing out what kind of memory difficulties or other cognitive difficulties somebody might have, and whether there's concern that this reflects something more significant, like an early or evolving dementia. And at that point, they can pass a referral on to the network of memory assessment services that we have nationally, some of which have grown up over the years, in various different locations, and some of which have been funded through HSE National Dementia Services in the last couple of years. Okay,
thank you, Seán. And Matthew, I'll come to you next. Matthew, as I said there, you're working in the memory clinic in St. James's. So Matthew, you see people day on day that are coming to you with dementia, and we have recognised there that it is a tough diagnosis. But I also hear you talk about hope. Small word, but a very strong word, right? And maybe, Matthew, if you tell us a little bit about when you see people and the hope that you can give them when they visit you in your memory clinic.
Yeah, thanks, Sarah. I guess when we're first off, no two people are the same. So our experiences within the clinic are obviously very individual, and we have to treat people individually as they approach us. I think it's very, very complex. Let's face it, we're not giving good news when we're in these situations. Now, saying that, some people do expect to have a diagnosis given. Other people, it comes as a complete shock. So we have to be prepared for whatever way people approach that. Because of the differences, I think the whole concept of fostering hope in the communication of the diagnosis is perhaps the most important part. The way that we do it within our service is that we concentrate very much on things that we can do. So we know from a medical point of view there are certain medications that can help. I think some of it depends on the actual subtype of diagnosis that we're given. So if, for example, we're giving a diagnosis of a vascular or a mixed dementia, there are certain medications that can play a big role in stabilizing a condition, or at least treating symptomatically. So that's very important. So we would look at things like the medication. But we'd also look at how we can help the individual manage on a day-to-day basis. So we would be very much concentrating on how people can maximize their remaining abilities and minimize the areas of disability. So that would be a priority. I think also looking at some of the practical things that we can help people with. Certainly within the St James's catchment, we're looking at people who are perhaps in some of the most deprived areas in the country. So we can also look at ways we can maximise income, for example, and that can make a big difference to people. So there's various different ways that we approach that, but it's a lot of it is about trying to help people maintain their independence, not panicking over the diagnosis. I think also we can also think about the age cohort that we're dealing with. I think sometimes we reframe people's perceptions of what dementia actually is, and that can be done in different ways. For example, for Alzheimer's disease, the vast majority of people who are developing Alzheimer's disease are in the older age cohort of society. So sometimes it's with those types of dementia, they tend to rumble along quite slowly. So we would talk to people about the fact that because of their age and the presentation, and perhaps it's very early in the process of the dementia, we would talk to them about the fact that yes, they're in the memory clinic. We've been giving them a big workup, and it's culminated in this diagnosis. But at the end of the day, if they were to come back and see us again in a year's time, in practical terms, there might not be a huge difference in the way that they are managing on a day-to-day life, in their day-to-day lives. I mean, we might see a drop-off in their scores or certain types of their presentation, but that in their day-to-day lives, it's perhaps not the biggest thing. And even just reframing it in those kind of terms can make a big difference to people's outlook. I think there's a lot of stigma around, obviously, about dementia, and I think, perhaps just talking to people in slightly different ways about what dementia means and how people live with dementia it is very important.
Yeah, and I always love that way when I'm always talking to you there, Matthew, that you do actually, talk about that in relation to dementia, and you always give that hope of say, you can live and you can live well with dementia, and it is all about what we can do. I know you always talk there about staying connected and the importance of that, and particularly in relation to with people with dementia. Maybe say a little bit about that connectivity and staying connected with people with dementia.
Yeah, I think Sean touched on it earlier there. We know, and I'll answer this in two slightly different ways because I think it's important to get the kind of brain health message across here as well. So social isolation, we know is a risk factor for dementia. So if we can minimise that as much as possible with the people that we're working with, and with the general population as well, I think that would make a huge difference in certainly in some of the numbers of people presenting with dementia, and also how people live with dementia as well. I think it's very important. I mean, there's a lot of kind of recent research. I mean, Sean touched on the Lancet Commission there, but there's I think Alzheimer's Research UK came out with statistic recently where they reckon there would be 5 fewer people per 100 presenting with dementia if social isolation was addressed. So that statistics like that are quite important. Will make a lot of big difference, societally anyway. I think we're not quite sure why people become why social isolation is a risk factor. I'm not 100% sure why that is. It's possibly because people who are socially isolated aren't engaging and they're not activating their brain to the same extent as those who are kind of busily living their lives. We know that social isolation is a risk factor in as much as it can lead to depression, and we know it's very clearly stated in research that depression is a major risk factor for depression as well. So if we can minimise that. There's also a suggestion that people who are socially isolated perhaps have poorer health outcomes. They're perhaps more prone to drinking alcohol, maybe smoking, exercising less, and things like that. So that can lead to it being a risk factor. For the other side of that question is for people with dementia, who perhaps are becoming socially isolated. I think the feeling there is that, again, we're not quite sure what happens there, but what we do know is that people with dementia tend to withdraw. Both kind of their geographical world starts to shrink, their social world starts to shrink, and there could be a number of reasons for that. It could be that they're feeling maybe more disorientated when they go outside and beyond their normal comfort zones. Perhaps they want to stay within the home and family settings a bit more, and perhaps they're feeling a bit more awkward, in communication. So there could be a number of reasons why people with dementia become socially isolated. But we have to try and challenge that. I think individually, I think societally, and as a nation, we have to try and change that. I think organisations like Understand Together campaign, I think, are very important in doing that, because they're engaging in the wider community to recognise dementia, be more dementia aware, and to encourage, whether it's transport providers or service providers, shops. It's about all of those recognising that people with dementia are there and trying to include them so that we're not creating the barriers that prevent people engaging in their wider lives.
So two great things to out there, the social isolation, and look, we all know what COVID told us in relation to how much we belong to the tribe, and we do need to connect and be out there in society. So actually in having that in. But I also love there, Matthew, and of course, because I'm coming from Healthy Ireland, and of course the whole agenda there about what we do with our lives, and Seán referred to it earlier, and the lifestyle behaviours and how the important role that can actually play both for every part of our lives and how it can actually prevent us from getting many different chronic diseases. So I'm going to move across now to you, Ken, right? Because we've now heard here all about dementia, and we're talking about the health service here for it. But Ken, we're here, and the reason we're here is because it's like people like you, because as I said earlier, you have been looking after your father and supporting him who has Lewy body dementia for the last 15 years. And as Seán has called out there, Lewy body dementia presents itself in different ways, right? It can actually have the hallucinations, falls and disturbed sleep, and that the memory loss may be actually that bit less or not as prominent as in it. So I know that from your father's experience there that you've always been talking about the importance of diagnosis, and I am going to ask you to take us on that journey. But before that, I just want us to take a minute there to look at that picture of yourself there and your dad, Dave. It's shot up there on the screen because I know it's your dad, David's story that you're actually telling, and I want to recognise that, and I know that it's not easy. But you have a very powerful story to tell, and I'm sure our audience would love to hear that story, Ken, on that journey with your dad for the last 15 years.
Yeah, thanks, Sarah. It's great to be here. It's such a great panel, and thanks for allowing me to talk about my dad. I suppose you can see by the picture there, I know it does literally paint 1,000 words. Myself and my dad would have been very close growing up, so I'd have known him very well, along the journey. And I suppose in 2010, I noticed that my dad had an absent arm swing and an unsteady gait. And just for context, in 2009, my mum unfortunately died at the age of 53. So Dad at this point was 57. So I would have brought him into a specialist, and at the time he was diagnosed with depression. They were done an MMSE test, which wasn't of any help for his illness. And he was just diagnosed with depression. Initially I was kind of relieved by this because I thought, well, look, it's not something sinister. At least now I can work with him and I can help him to get better and support him in any way he needs. And just for a bit of a backstory there, in 2006, Seán had touched upon them, the REN sleep disorders were present also. So there was a history there right up to 2010 of what Dad was dealing with throughout those years. So I ended up going back to the specialist several times because Dad wasn't getting any better. He kept getting worse, he was struggling, he had no quality of life. I'd gone back several times and still was told, done the MMSC test again, and was told, oh no, he has depression. There's nothing, nothing wrong with him outside of that. I was becoming increasingly more frustrated, obviously, because I could see Dad suffering. So in 2013, just by magic, but through my own research, I came across a scan called a DAT scan. And bear in mind, I'm only 29, 30 at this stage. I don't know what a DAT scan is, but it just seemed like this could help my dad. So I went back 2013, 3 years after being there, and actually insisted that we actually put him forward for a DAT scan. The DAT scan came back and it showed up abnormal levels of dopamine in his brain. So at that point, the specialist would have diagnosed him with Parkinson's-ism, which was also devastating, but at least I felt now I have something I can research and I can help him get a quality of life with the support of medications and support in the community, and maybe give him some, understanding as to what he's dealing with. So I suppose what happened after that was that the medications, he was hypersensitive to the medications, as people with Lewy body dementia are, and he was affected by all the contraindications. And 2 years passed, and we were going out of our mind. We were crazy with worries, stress. Dad was suffering, and we said we better get a second diagnosis. So we got a second diagnosis, and the second specialist was unable to confirm his diagnosis of Lewy body dementia. What they did say was that they're not happy to confirm Parkinson's-ism. So we left again, not knowing, still in that kind of emptiness of what's going on here. And Dad was continuing to get worse as the years went on. We tried him on various medications. He was like a pincushion. His life was, it was so tough for him. So what happened then in 2017, I had enough. And I just couldn't cope anymore. And myself and my wife took my dad in with the support of the GP, and we started to wean him off all the medications that he'd been on over the years. And I suppose what presented itself then was severe hallucinations and delusions. And we documented all this and detailed it very clearly. And what happened then was actually, I was in work one day at my office desk, still doing research, and I came across a 15-point checklist from the Lewy Body Association in America, and I checked off every single one that Dad had. I'm sorry, it's just quite so emotional. But basically, I discovered my dad had Lewy body dementia, and we went back down to the specialist, and they confirmed it was Lewy body dementia. But even after that, for 4 years, it wasn't until 2021, through setting up Lewy Body Ireland, we met somebody who kind of truly understood his illness and what it was. So when we talk about early diagnosis, it's not just getting a name of a condition. An early diagnosis is so important because it opens up a whole pathway, like Seán talked about, for people to access the care and the support and the proper interventions that they need at a time when they need it most. And if I could just give one message to people who may be out there, who are living with dementia, who are dealing with dementia, family members, that you are also an expert in dementia. You must record and detail everything that's happening. And in conjunction with the medical people, work together. And that takes both sides, right? But I mean, the nuanced data required for early diagnosis, it's not achieved in a doctor's room. It's achieved in your daily lives. It's achieved day by day, hour by hour. And it's so important to detail them because your voice is the most important sound in this journey.
That is a really challenging story, Ken, but I can really hear the voice and the passion that you're bringing to it. And I do actually say how right that is in saying we all have that role to play in relation to dementia. And taking out there the accurate diagnosis, and I've heard you saying it opens up so many doors in relation to the treatment and where to go from there. Another piece there, Ken, that you actually recognise is about supportive communities and support that people like yourself and families like yourself actually need. And I know that you felt the support with the care of your dad as well too. So maybe if you share that story as well with us in relation to some of the supports that you got along the way.
So when we're talking about support, I suppose community is the most important support in dealing with dementia. And community for us is, being able to help other people and being there for them, knowing that at a time when you need help and you need support, that's there for you also. So we're all very interconnected. Community isn't just a thing that people organise outside. Community is a real thing that we all have to take part in and devote our time to. And I suppose when Dad first got diagnosed, people were great. I mean, the community, his friends came around, took him to matches, and were there for him. But unfortunately, as his illness progresses, and this may be common of people listening in today, that people were slowly moving away from him because the question they'd ask me was, does your dad know you? And I know that was their way of not being able to process or deal with probably him not knowing them. So people move away, and with no badness and no malice, but they move away because they're unable to cope. And that was very tough for dads, but thankfully in 2018, Dad agreed to go into a care by community, and it was a dementia-specific village, and in the first 2 or 3 years there he flourished. It's a community of people with a cafe. There's only 3 houses, 18 residents, and people were moving around, supporting each other, helping each other. And I saw him blossom again. I saw him come back to his humour. I saw his smile. At this point he was walking and he was interacting, so he could really benefit and, you know, get a value out of that. Unfortunately, we took another twist in 2022 because Dad had been suffering from falls. So COVID had happened, as we said, in the social isolation that, you know, went with that. But Dad had been kept in his bed for long periods of time to mitigate the falls. And I suppose we didn't come aware of this till 2023 when I went to visit Dad. He was in his bed and he was having epileptic seizures, persecutory hallucinations, aggression. He was lashing out. After everything he'd been through, I was thinking, oh no, my dad now has to go to a secure unit. I was absolutely devastated. My hair, I couldn't sleep. So what happened was a new manager came into the care facility and we worked closely together. But I reached out to people I knew and we kind of basically were trying to, you know, check off what he didn't have to see, you know, how we could help him and support him. So really as time moved on, and we talk about community, this is a community in a community, and this is how important it is. So 2023, I thought my dad was going to a secure unit because he couldn't cope. In 2024, by a simple measure of bringing him out into the communal areas, providing him with proper chairs to keep him comfortable, talking to people, watching people, engaging with people, that actually brought him back to life. Fast forward 12 months, my dad has no more persecutory hallucinations. He doesn't have any epileptic seizures, and he has smiled more in the last 12 months than I have seen him in so long. And I suppose, you know, that's exactly the power of community. And, you know, if we can get one message out here today, it's that, you know, as I said, community is a nice idea, but it's only important when people devote their time to it. And I suppose if I can just end on time and how important it is when it comes to community. When I was 14, and I used to work with my dad doing carpet cleaning at a carpet cleaning company, he'd always stay back and do extra work for people and charge them less money. And I remember coming away from him, and I remember it stuck in my brain going, why do you always do that for people? And he goes, Ken, he said, no matter how much money you have in this world, the greatest gift you can give anyone is your time. And I think that Dad instilled that in me. And I think that throughout the years, the 15-year journey we've been on, it's exactly what I saw him do for other people. You know, when he was needed, that I'm able now to give back. And all I ask is that, I suppose people do that for everyone with dementia, to allow them to live with dignity, to allow them to live fulfilling lives, to experience joy. And that is through socialization, and it's through time and community, and it's through recognizing that this is going to affect us all and we should be there for everyone at any point we can.
Well, Ken, as I said, that is a powerful story. There's so much that you've actually said in that and called out. I love that piece. The best we can give to people is time. And Ken, you're giving us your time here today. But not alone that, you've given a lot of your time. And I do hope that you do get that great sense of achievement, because I know it was through you telling your dad's story that actually made a big difference and did influence the securing of the grant of 2.5 million, I think it was, in relation to for the Emerald Lewy programme through Trinity. So that is a huge achievement in relation to that. And we really do thank you for that. And we're talking about community. We're all sitting here, we're all wearing these blue badges here today to say understand dementia. And it is, and it's a great campaign, and we'll talk a little bit about that later in relation to trying to get us all to understand the dementia and to actually be supportive and not to forget about the people and to ask the right questions from there. So Ken, thank you so much. So, as I said earlier on, we have a great audience, the 1,700 of you out there listening to us, and we want to give the opportunity to actually see what are you saying and what are the questions that's coming. So we're just going to switch now to the questions from the audience, and I'm delighted and thank Paul Maloney here, who is the Programme Manager from the National Dementia Services team, who is managing and looking at your questions. So Paul, have we questions from the audience, and do you want to put some of those questions to our panel here this morning?
Thanks, Sarah. We do indeed. And just bear in mind, we're running a few minutes behind, but please bear with us. And we'll get through some of the questions. In the interest of time, we probably won't get through all the questions, but we picked out a sample which I think it reflects the overall interest in various areas. So the first question I have is probably for Seán. And I suppose, what are the new drugs that we hear about in the news for Alzheimer's disease?
Oh, yeah, so that's a good question. So there are new medications on the way for Alzheimer's disease in its earliest stages. And essentially, the European Medicines Agency has recommended that they would be approved for use. So we will anticipate they'll come into use in Ireland over the next year or two. And this is a paradigm shift or a game changer for people who are in the earliest phase of Alzheimer's disease. But I think it's important to realise that these medicines will be for a tiny proportion of people who are living with the diagnosis of Alzheimer's disease today. And it's really more, I suppose, for that group of people in the short years to come who present early. And that's, again, I suppose, why it's really important that people are, encouraged to come forward for early assessment, and that we're all more aware and confident in recognising mild cognitive impairment as a forerunner of Alzheimer's disease for some people, because that's the group of people who are in the mild cognitive impairment or in the earliest, mildest phase of dementia that these medicines seem to help. The effects are relatively modest, but nonetheless are encouraging, and I suppose we talked a little bit about hope earlier on, and from the perspective of the future, it gives us hope that these neurodegenerative diseases are something that we'll be able to meaningfully change the course of and modify in the years to come. But they certainly will not be a panacea or something that are without their own difficulties, their own side effects, and it'll be a very small, sort of carefully selected group of people who will be eligible for them.
Thanks very much, Seán. The next question we have is quite a common one, but a very tricky situation to deal with at home. And I might give this one to Matthew, actually. My mother gets very defensive when the subject of memory is raised, and there's obviously clear concerns here. So what advice could you give to, I suppose, to take the next step?
Stay friends. Stay friends, most definitely. I think you just got to treat each situation individually, not to panic. We know at the moment, even if somebody has got a dementia, if they're not taking the medication, it's not going to make a huge difference. It's certainly not worth falling out over. I think you've just got to take things gradually. At some point, there may come an opportunity to introduce the suggestion of perhaps going for assessment or for a checkup with the doctors. And I think just take it easy, not to panic. It's not worth rupturing a family or a relationship over, absolutely not. I think you just try and, as I said earlier, just try and live with it, try and minimise the areas of difficulty and maximise the areas of ability, and just to take things nice and easy, keep things as normal as possible.
And if her mum starts to come around to that thought process, I suppose, what's the first logical step to take then?
Well, visit the GP. Visit the GP. GP's access to all the services. You can't jump into secondary, like hospital level, without going through the GP first.
Brilliant. Thanks very much, Matthew. My next question is probably more for Majella. I suppose, what, in your opinion, is the most important piece of advice you can give to someone after a diagnosis?
Well, thanks, Paul. I suppose all information is important, and we spoke this morning about, being socially connected and pharmacological and non-pharmacological interventions. But I suppose we have to be physically well to mind and protect our memory after a diagnosis. And something that Seán touched on earlier was, delirium. And delirium is caused if we have a physical illness or a response to maybe infection, medication. And if that happens, it can really cause our memories to fluctuate and cause us to become unwell, and can often propel us towards a hospital admission. So I suppose for us as clinicians to really educate people who receive a diagnosis of dementia and family members that are supporting them. And just, I suppose, another piece of information that I would always say to families in my role as a clinical nurse specialist, and can very much put that message out there. A family member or someone that is living with somebody day to day is the expert on the person who's caring for somebody. So if somebody is presenting in a manner that you're supporting and you're living with them with dementia, and you feel they're unwell, there's something that's causing maybe their memory to fluctuate outside of their daily pattern, it's important to go to your GP get the person reviewed and to address the delirium quickly, because we need to mind our memories going forward.
Very good. Thanks very much, Majella. In the interest of time, I'm just going to hand you back to Sarah, but lots of resources are available and will be circulated at the end of this webinar, so don't worry if your question was unanswered. There's lots of resources available. Thank you very much.
Thank you very much, Paul. And Majella, you're in a flow there and you're talking, and as I said earlier there in your introduction, you're in the Memory Assessment and Support Services, and there you're based in Sligo. You know, that's a service, maybe we all don't know very much about it. Will you tell us a little bit about that service?
Yes, Sarah, thank you. But just before I go on, I'd just like to thank Ken for sharing his story with us, because for the public, you know, that whole information piece and awareness there's nothing like the lived experience. And I think for us as clinicians, we can never hear those stories often enough to remind us, you know, what we do every day and how important and the impact it can have for people going forward. So say thanks, Ken. Yes, I work as a clinical nurse specialist in dementia. We're based in Sligo, but we cover quite a rural population, and we would cover Sligo, Leitrim, South Donegal and West Cavan. And I'm one of quite a large multidisciplinary team at this stage, and we've grown. We're one of 3 active memory assessment and support teams in the country. That was developed from the dementia model of care. Sean mentioned earlier the dementia model of care that was brought out in 2023. So we're considered a level 2 memory assessment and support service. And to give people an idea of who would come to our service, obviously there's people that have concerns about their memory and they are coming for assessment and a probable diagnosis. But we would also see people and accept referrals for people that have a diagnosis elsewhere, be that maybe more locally at a level 1 or in a regional memory assessment service. And they're coming back locally to our area for post-diagnostic support. And then kind of a third kind of branch to that would we focus on brain health advice. So we're kind of encompassing all the journey from assessment right through the person's journey of dementia. Suppose to give people an idea of what happens when you come to our service. You know, our assessment starts very much maybe perhaps before the person presents. So Ken, you know, advised there and told us how the person living with somebody who is presenting with maybe symptoms of dementia has all this information, and how important it is to note that. So before someone is invited to an appointment at our service, we would send out what we would call a pre-clinic questionnaire, and that we would invite the person that has concerns with their memory to ask a family member or someone that's supporting them or living with them to complete that. And it's back to that whole thing of time. You know, the person has that opportunity to sit down and reflect on what they see happening for their loved one and completing that questionnaire. So they're bringing that information to us. So it starts way before they come to meet us at the service. At the service itself, without going too much into the minutiae, we would carry out a cognitive assessment, a functional assessment, and a physical assessment. So it's we would call it a comprehensive diagnostic assessment. And that information, along with perhaps some imaging that may be appropriate, would be brought to the wider team, and we would discuss that. And as I say, we have a multidisciplinary team, and there we would discuss that. And depending, and again, back to as Matthew said, depending on the person, their individual needs, different team members may input. And then from that, we would meet again, and it would be decided that the person has a dementia, and then a meeting is set up, and time is given to that meeting to give a disclosure of dementia. And time, it's a big diagnosis to give, so it's really important to give that time.
And Majella, when somebody has come to you and when they're leaving you, what are they going home with?
I suppose to answer what what they leave with, I suppose, very important for us to understand what they're coming with. As Ken said earlier on, people are anxious, they're worried, they're upset. The person themselves, may not be aware of the impact that their memory problems are having on themselves, and it could be, a loved one that has highlighted this. So we have to really recognise that what the person is coming with, to give them the appropriate information to leave with. Our information, obviously, there's the pharmacological input, but from the other side, the non-pharmacological information we would link people to local services, be that our the dementia advisor, social prescribing, local voluntary agencies, for example, the Alzheimer's Society of Ireland, Family Carers Ireland, alone, just as examples. But from practical day-to-day advice, if it's appropriate, and again, this is all very dependent on the age of the person, where they're at in life. For somebody that's quite young, if they're still working, have a young family, the information they require might be very much different to somebody that's much older, has retired, and has different family supports around them. So information is very tailored. But examples of information we would give would be information and support around driving. Again, as I mentioned earlier on, delirium being the key piece of information, future planning, be that, and the whole legal aspects and financial planning, where appropriate, information around the decision support service, local primary care services, and all that whole host of brain health strategies and brain health advice.
And Majella, we've touched there about community, and look, at most people with dementia live in the community. Now, you're seeing people day in, day out in your memory assessment unit there. What does community support look like to you? You see it, you hear about it. What does it look like, and in helping the person with dementia to stay connected?
Yes, so as we said earlier on, a huge percentage of people that has a diagnosis of dementia live in the community, up on 63%, and that's why it's super. The Understand Together campaign, promoting awareness is huge, and then when we're aware to have services and linkages into our community to meet that is really what we need. There's huge research, as Matthew said, and studies into the importance of that whole social connection. It is that whole feel-good side of it, but there is the whole science to it. When our brains are cognitively stimulated, it helps, promote our neural pathways. So there's science behind this, apart from, we all naturally feel better to be part of a community. And what that looks like, again, is very individual. Again, depending on our age, our where we live, what we're interested in, and it comes back to that whole person-centred piece. And person-centred is something we say a lot, and it's a term we use a lot. But I suppose to be truly person-centred, we have to understand, what people are interested in, what they enjoy, what they don't. And be that for some people, it might be, being part of a local choir, a social community group. But for people, they may be more therapeutic, dementia-specific activities, like perhaps, COGS Club. We have our local MTRR room that runs a memory strategy group. Within our own service, we run some memory strategies. And then outside of that, there's the Alzheimer's Society cafes, social clubs. All of them are hugely important to connect people, because ultimately, as Matthew said, we all need to have hope, enjoy our lives, and live fulfilled and a good quality of life.
Thanks, Majella, and I suppose we can't emphasise enough the power of the community, and I say again in relation to that wonderful campaign that has been led out about Understand Together, and you can look at understandtogether.ie, and that's what we're all promoting here with our little blue badges that are there in relation to it, because we all can make a difference. So Emma, I am finally coming across to yourself, and Emma, really interesting, you're in the Memory Technology Resource Rooms, right? So a service here that's for us. Emma, tell us a little bit about this service. Take a bit of the mystique out of it for us.
I will. So the Memory Technology Resource Rooms are a post-diagnostic service, and we are on that dementia care pathway. So oftentimes our referrals will come from Majella services, the memory assessment services, local memory clinics or regional memory clinics, as well as our local community teams like ICPOP teams, which is the Integrated Care of Older Persons programme. Our service is facilitated and managed by occupational therapists. We provide people the opportunity to learn how the, I suppose, non-pharmacological interventions can support the person. So things such as the cognitive rehab strategies. It might be a program that we run, like the Memory Strategy Education Group. It can be supportive routines, adapted environments, and hugely we would advise on assistive technologies. And these all can help support a person to remain independent, to remain engaged, and to be safe at home. So as occupational therapists, then we would focus a lot on the functional impact of dementia and how the changes occurring in the brain can, I suppose, impact and implicate on how a person can maintain their skills and acquire new skills. We recognise that each person experiences dementia differently and will bring with them different attitudes, different values, and equally different support systems. And so we would recognise that through providing a very much person-centred approach through our assessment and intervention.
And Emma, if when somebody goes to your memory technology resource room, what's a visit like? What's it like?
Yeah. So a session at the Memory Technology Resource Room, a client will be interviewed by the occupational therapist through an informal process. So we're not heavy on assessment, it's very much informal interviewing. This allows us to gather information and to understand from the person's perspective how dementia is impacting on their everyday lives. We encourage a family member to attend also, and this is really important to give us insights and their information, and also so that they can be supported and learn how to support their loved one. Depending then on the client's priorities, each case will vary, but we aim ultimately to provide education and advice relevant to the person at their current stage, but also for their future. So by introducing some protective strategies now is really good for, I suppose, if you can build and work on some strategies early, it can stand to you as dementia progresses.
And for assistive technologies, how do these help people with dementia?
So assistive technologies are excellent. They're really very supportive. They can help compensate where, I suppose, the dementia is creating challenges. They range from very simple, low-tech things like orientation clocks to very high-tech GPS and activity monitoring. If we consider somebody who has disorientation and is forgetting what day of the week it is, or, this can really impact negatively on their day, and it might mean that they forget an appointment, they might arrive at an event on the wrong day, or they have increased anxiety, unsure about who might be calling. That it's a very disruptive thing not to know the day. So a very easy orientation clock that automatically changes. So it will tell you the day and the date and the time. In your kitchen, somewhere visible, is a really good place to gather that information so that it can root you and anchor you in your day. And then, of course, used with the diary is really important too, so it can highlight who's calling. And ultimately, this gives that person that independence, alleviates those issues, and can reduce anxieties.
And I suppose safety at home is a big thing as well too, in relation to trying to keep people safe in their home.
Yeah, absolutely. Telecare is actually a really good support system for the home and to keep people safe. It can, I suppose it's a layer of security for families, and it will alert families to potential risks. And so I guess currently what's on the market that's available that many might know is the Senior Alert Scheme. And this is the little wrist pendant, or you can wear it around your neck. And you have to actively press this button if you've had a fall or if you need help. In dementia, oftentimes when I talk to families about that, they will say, oh, they won't remember to press it. Rehearsal and practice every day of something is really important. The person can create new, memories, but it's the practice every day that's ultimately what's going to support the person. So if you practice every few days to press it, this is great. If in a year's time the person needs this device, they're very used to knowing about it because they're used to rehearsing it. I guess the other thing that you can do with telecare is that you can independently then buy other sensors. So maybe you might put a door sensor or a flood detector or a smoke detector, and these all feed into that same system and can alert any potential risks as well.
And Emma, I'm going to ask you, I couldn't let you off without asking you and put you on the spot. Everybody talks about AI now, artificial intelligence. Has it a role in the future for dementia?
Yeah. I guess so. I mean, if you look at it with activity monitoring, it could be a good support to identify some gradual changes. So maybe, over a few months, it will start to notice with sensors within the home different subtle changes that a person with dementia just might not be able to recognize or their family to even see. And so this could really help around early interventions and feedback to healthcare professionals. Maybe these slight changes that we could start to modify and reduce that risk and keep people at home for longer. Hopefully, that's potential, I guess, of AI. Yeah.
And I can see there from our audience there's a great interest in actually knowing how do you get the assistive technologies. So anything that you can share with us there on that?
I suppose the assistive technologies are very much from specialist stores. That's why we wanted to have them on site to demonstrate, to work through, to show you all the different, very easy items there. They have always been a paid private purchase, but recently we've just engaged with the Department of Health to research a pilot project. So the Memory Technology Resource can now provide you with certain technologies, more the kind of top ones that we know can be really helpful. So I would recommend people make that appointment or get that referral to the Memory Technology Resource Room. Not all technology will support people. We have to be considerate as OTs of their environments, their symptoms. If they have hallucinations, delusions, this might really not work very well with certain things. So an assessment is ultimately really important, and hopefully we'll be able to give you those technologies on the day or the simple strategy. Yeah.
Okay, thank you very much, Emma. Look, we could stay here for hours more talking about, as we said, let's talk about dementia and talking about, knowing more about it and understanding about it and the services that are available there in the health service and also that key role and the supportive role that we have in the communities. Seán, I asked you to open our session. We're coming to the end now, so I'm going to come back to you there and actually maybe just say a few words maybe to our audience there about the Understand Together campaign and that important role that's in it.
Yes, I think the Understand Together campaign really sort of encapsulates what we all, should and need to do to make dementia something which is recognised, destigmatised, both in healthcare and in our communities. And I think the messages that are really championed by Understand Together and by the community champions are really key. Simple things like seeing the person, not the dementia, and asking how you can help. And in a healthcare setting, as we said earlier on, a large number of healthcare interactions in the acute or in the community setting are with people who have cognitive impairment or dementia. And as Ken said, really we just need to be mindful of how we can support these people by giving them that bit more time, that bit more empathy. We're all very fixated on productivity and KPIs. There's no KPI for kindness, but there probably, I hope there never will be, but that's really, I think, the message that I think we should all be trying to convey, just giving people a bit more time and a bit more empathy to encourage them to live their best quality life that they can.
Thank you, Sean. So I suppose that really is, I was looking for a take-home message. So I suppose that's really your take-home message that you're saying for our audience here today.
Yeah.
Absolutely. So with that, I want to close and I want to thank our wonderful panellists. As I said, we had a great level of expertise here in the room today. So I want to thank all of you for giving of your time. I want to particularly thank you, Ken, for coming and joining us and again in sharing. And I do wish very well, and I do wish good wishes out there to your dad, Dave, and I hope that he will continue to do well. This webinar was brought to you here from Healthy Ireland and through myself here, Sarah McCormack, the National Lead for Healthy Ireland. But I could not do that without that wonderful and collaboration here with the National Dementia Service. And I also have to call out some people that I just work day in, day out. And one is going to be Fiona Foley, and I know she doesn't want me to call her out. But the day-to-day work in relation to the Understand Together campaign, Paul Maloney in relation to the National Dementia Service, working there along with Dr Seán O'Dowd and the team. And of course then to Fiona Donovan and Caroline Gunn and Noreen Turley, who did such wonderful work on the technology backup. I know we had a blip in the beginning, but that always happens. So I do apologise for that. And as we leave the session today, I do want to thank you for joining, because you are our audience, so thank you very much. And as I sign off here, as Sarah McCormack from Healthy Ireland, I want to give the last word to Kevin Quaid. And Kevin Quaid chairs the Irish Dementia Working Group and European Working Group of People Living with Dementia. He is also co-founder of Lewy Body Ireland and the author of 2 books about Lewy body dementia and his own journey with the condition. So as I say, slán slán, stay well, be active in your community. Let's hear the words from Kevin Quaid.
I'm Kevin Quaid, I'm 55 years of age. I'm a passionate Limerick man, but I'm living in North Cork. And I was diagnosed with Parkinson's disease just over 3 years ago, and with Lewy body dementia about 2.5 years ago. Thank you, my usual. At the moment, I am, I suppose, what you call semi-independent, in that I'm living at home, and Talina, my wife, is my full-time carer. It means I can live a pretty normal life. Cheers, lads.
Aye. Cheers, buddy.
It's not just living within these 4 walls. The people in my community involuntarily have become my carers part-time, if you like. I have a great life because I have a balance in my life. And the balance in my life is when I can go into my local Lincoln Turk, sit down, have a drink, be one of the boys, go to the local coffee shop, have a coffee, be just an ordinary customer. I got diagnosed with Lewy body dementia that day. My family were diagnosed with it. And I can tell you from personal experience, it's a lot easier to have it than live with someone who has it. But we as a family have discussed everything from me not knowing who I am, nursing home, funeral, driving, power of attorney, you name it. So when the day comes that I can no longer pretty much do anything for myself, or I can't be left alone, the family know what Dad wants. Helena knows what her husband wants. Do you know what? This is home care at its finest. At its finest. You won't get, when you're capable of doing this, and there's people with dementia in middle stages and even late stages, they can go, listen to that, they can go for a walk, see this, because by God, it means a hell of a lot to me. I don't have to be inside in my cottage. I don't have to be outside in my rose garden. Once I'm in my community, I feel I'm at home. When you're diagnosed and when you're told you have a disease that's progressive and incurable, and you know, even saying it now, it chokes me up. But you can live with it and you can live well.